Yes.
Dr. McClelland, I'm going to ask you to look now at a report you made following your visit to New York and your attendance at the World Health Organization meeting on AIDS in the autumn of '83. WITN 6666011, please. So this is headed draft, but it's the version you've exhibited to your witness statement, Dr. McClelland, and I don't think we have a different version of it. And we can see it's a report and proposals prepared for SNBTS following a visit to New York in October/November '83 and participation in the WHO meeting on AIDS in November 1983. If we just go to the bottom of the page, you say in the last few lines there, several sets of recommendations relating to AIDS have been produced by various bodies in recent months. Recent recommendations which have arisen in a European context are those of the Council of Ministers of the EEC. So I think that probably answers the question earlier that you had seen in 1983, not necessarily in June, but in 1983, those recommendations. If we go over the page, if we go to page 3. Bottom of the page, we have the heading Transfusion-Associated AIDS. You refer first of all to cases reported in haemophiliacs receiving factor VIII therapy. And then in the US, as of November '83, there were 30 cases of AIDS in patients who had no identifiable risk factor other than receiving transfusion of blood or single donor blood products during the 5 years before onset of AIDS. You say you were aware of a single similar case in the UK and no other European reports as of December '83. And then if we go to page 6, you say this: although we do not know whether transfusion-associated AIDS will prove to be a significant problem here, it is highly desirable that an effective approach should be made to both prevention and investigation at this time. Ideally, this should be seen in a UK context and coordinated with efforts related to other aspects of the AIDS problem. Furthermore, such efforts should be planned against the background of comprehensive information about actions being taken in other countries to ensure that resources go only to studies which are likely to provide additional information relevant to the UK situation. And then the next paragraph, you say, at present, there does not appear to be any centralised approach by the UK transfusion services. The topic has been discussed at meetings of the transfusion directors of England and Wales and of Scotland, at the CBLA Research Committee and its AIDS subcommittee, at the Transfusion Directors Working Party on Transfusion-Associated Hepatitis, and at a working party of the UK Haemophilia Directors. None of these bodies appears to be in a position to direct funds to studies on AIDS, and it is understood that in Scotland, funding requests for research related to AIDS would at present be referred to the MRC. And then you say this, by way of proposal, it is proposed that consideration be given to establishing a single group to address the problems of AIDS in relation to transfusion in the UK. To be effective, such a group would require access to substantial resources earmarked for support of suitable programmes related to AIDS. Ideally, such a group would operate in the context of a national working group with a remit to tackle the whole problem, and then you refer to such working groups having now been established in Canada and Australia. Now, was this a proposal that you were directing to SNBTS, essentially for Dr. Cash to take the lead? Or was this a proposal that you anticipated would go beyond Dr. Cash to SHHD or Department of Health? What did you have in mind?
Well, I'm sure it was sent to SHHD and probably to the appropriate person in the Department of Health as well, because at that time I would have known who that was. I imagine that my thinking at the time was that it was more likely to get somewhere if it was, spearheaded by ideally the Scottish National Medical Director and his counterpart in the UK, who I think had been appointed by that time. I can't remember, but rather than me as a little transfusion director putting this forward, I felt it would probably be more effective if somebody in a slightly bigger position was to promote it. I think that was my intention.
Do you think you had in mind the establishment essentially of a? Clearly you had in mind something that was UK-wide, but that was focused on and drew its members from the transfusion services, or were you thinking bigger than that to an eager expert advisory group on AIDS type body?
I was thinking much more of an eager type body because it clearly required. I mean, there simply was not the expertise within the transfusion services to deal with this problem, and that's not a criticism. It needed quite a lot of other skills.
If we turn on to page 9, we've got the heading Health Education directed at potential risk donors. You say, in the absence of effective screening procedures for donors at risk of transmitting AIDS, the most effective measure available is probably to persuade donors in risk groups to refrain from donation. The leaflet currently in use by the transfusion service is the only publicity measure directed at donors. This leaflet requires some modification and more uniform circulation to donors. And then you set out 3 proposals. First is redrafting of the Aids leaflet to make a stronger reference to risk of transmission by homosexual men, even if asymptomatic and having few partners. So that's the content of the leaflet. Your proposal 2 essentially is in relation to distribution of the leaflet. It should go to all donors on one occasion during the forthcoming year. And I'll come back to both those issues. But can I just ask you about 3? You refer there to further health education material to be provided to donors, which should deal with other matters relevant to donation as well as including reference to AIDS. Can you assist us with understanding what kind of material you had in mind there and what kind of other matters might be included in it?
To be honest, I can't now remember, but I think obviously I would have had in mind both some explanatory information about the exclusion, about other reasons for not donating, and other health reasons, so that donors had some background to what was in the questionnaire or later the interview. Possibly reference to hepatitis as well, including possibly non-A, non-B hepatitis. Sorry, a third thing. Yes, possibly, just a few very concise bits of information about what the donation is made into and, who it's for, how it helps patients.
And as far as you can recall, did that 3rd proposal come to fruition?
It sort of did, but I can't exactly remember when, because at some point among the many versions of the leaflets about AIDS, there was a leaflet produced which had a rather broader sort of health education flavour to it, which I have seen recently, but again, I wouldn't be able to lay hands on it.
I can try and pick that up overnight.
It was, I think, meant to be used as well as the other one. It was just to give donors, to sort of show to donors that we weren't only interested in AIDS, which could have been easily the impression they got.
You don't mention it here, but do you recall giving any consideration around this point in time, so in our autumn 83, to a broader health education campaign? So, because you're still talking here about, I think, written material that's given to donors, but there could have been a broader public health campaign. We know there was one later on, more generally in the 1980s. But was that something that was considered at this stage, which could then be tied to exhortations to people, to would-be donors, to consider whether they were potentially in risk categories?
At the time of writing this report, I don't recall, that I was thinking along those lines. I mean, the health education campaign, as I recall, the more general sort of public education campaign started quite early. Now, you probably have heard reference to the dreadful iceberg posters and things like that, which are produced. Whether that started with the expert advisory group, I have a feeling it started before that. And I think I had some involvement in it, but I honestly can't remember any detail.
And then if we just pick up at the bottom of the page, you turn to consider laboratory tests. You describe as the most effective way of improving the safety of blood supply would be by use of a routine donation screening procedure, which would reliably detect a high proportion of those individuals presenting to donate who have a high risk of transmitting AIDS. You say there's a pressing need for progress. And then you say the objective of effective donor screening might be achieved in two rather different ways. And if we go over the page, one is what I think we've been referring to as surrogate testing. Is that right?
Absolutely right, yes.
So here's surrogate testing in the context of trying to exclude people who may be at risk in relation to AIDS. And you give an example, the relatively high frequency of hepatitis B core antibody in homosexual men. And then two is specific tests that would identify the presence of the virus causing AIDS.
Two was, as I think I'm implying there, it may come up in other parts of the report, but the sort of the birth of the second methodology was already in hand, certainly in the Pasteur in France, in Professor Luc Montanier's lab, and Gallo in the United States was also progressing in this direction. So this was clearly going to be the better option. I think surrogate testing for HIV would have raised all the same problems as we will discuss about non-AMB.
We will indeed be discussing that tomorrow, Dr. McClelland. If we just go on to page 19, you talk there about, and this is the heading halfway down the page and then the last paragraph on the page, risk-benefit considerations in relation to studies to evaluate non-specific blood donor screening procedures, so surrogate tests. And you say the transfusion services exist to serve patients and the best interests of patients must guide our actions at all times. We must therefore take the most effective possible steps to remove any risk of transmitting AIDS by transfusion. However, in taking these steps, it's essential to minimise adverse effects on the donor population because this carries the risk of reducing the blood supply and thus putting patients at even greater risk. Donors could be lost as a direct result of a positive screening test result, such as antibody to hepatitis B core antigen, and then you give an estimate that this would result in the exclusion of between 0.5 and 2% of donors, depending on the region. Just in terms of those figures, that those do not obviously seem figures that it would be impossible for the blood services to deal with or make up through other means.
Absolutely not. I mean, if of course, as I think I've dealt with elsewhere, the problem of surrogate testing, as we're excluding a significant number of donors, even if it's only 2%, is you still have to work out how you're exactly going to treat those donors, because you're left with the problem of saying to them, sorry, you can't give blood anymore, but there's really nothing wrong with you, which is not a very satisfactory message. But I think I think by the time I was writing this, I was fairly confident that a specific test for the viral antigens for antibody to the virus would emerge reasonably soon. And this might have been a bit superfluous, to be honest, this paragraph.
Although you did then, if we go to page 21, you did set out proposals for studies on the value of non-specific tests.
Well, we felt at this time, we actually had a colleague, a consultant colleague in Edinburgh, Dr. Pengli Yap, and I sort of gave him the contract to go and research all the many candidates there were a whole rash of laboratory analyses that were proposed as possible surrogates for HIV. And we did look at them all very carefully with the view to possibly trying to evaluate one or more of them. But there was nothing actually very convincing about any of the reports. And we also had major problems in designing a useful evaluation. All we could really have found out was the rate of positive with test X in our donor population, but we wouldn't have actually known what it meant until we had a specific assay for the virus.
If we just go over the page, because you set out here that a protocol should be drawn up, and then the third paragraph, you say it's likely that to be evaluated, this study should have access to support for at least 4 years. At any time, however, the appearance of a specific test for AIDS infectivity could require the study to be wound down. It might be said, Dr. McClelland, that rather than expending energies on studies that would have to be carried out in order to tell you anything over a prolonged period of time, as you say here, a more precautionary approach might have been simply to introduce the testing in relation to the hepatitis B core antibody, because even if it resulted in a loss of donors, it was a manageable loss of donors in terms of quantity that you expected. Really on the basis that it's better than nothing when you're dealing with a disease which numbers are increasing in relation to transfusion transmissions in the States, and where you've got very little else in your toolbox to equip you to deal with it.
No, I understand that argument. I actually can't remember now what the actual numbers in relation to how effective core antibody would have been in predicting the presence of HIV, or in predicting infectivity, which is actually all that we could have determined at the time. I think the reason that I wrote this goes back to my experience quite, some few years, not all that long previously actually, when I had been sort of battling a similar issue about surrogate testing for non-A, non-B hepatitis, when I had worked very hard to develop and promote a prospective study to actually determine in a controlled way the impact that surrogate testing would have on the incidence of non-A, non-B in recipients. And that was modeled on, based on information that I'd obtained and largely copied with permission from the TTV study in the United States. And as it turned out, that would have probably saved us quite a lot of problems in relation to deciding about surrogate testing. I think I was probably thinking along the same lines here. In answer to your question, would it have been appropriate to introduce core testing at this juncture? What would it have achieved? I mean, we'd have to have information to answer that question. We'd have to have information that we don't have. If you you have to know how often a positive core test would be associated with infectivity, HIV infectivity. Later on, you would have to know whether a core test was reliably associated with HIV detected in the blood or not, because it is possible that there would be virtually no overlap between a positive core antibody and the presence of HIV, in which case you would be excluding quite a lot of donors for absolutely no good purpose. This is essentially the problem with surrogate tests, and very, very difficult to assess in HIV because the incidence of infections was at that time extremely low.
Just one further
I'm sorry, that may not be a very clear answer, but I hope it's clear enough.
There's just one further passage from this document, so could we have it back on screen, please, Sally, WITN 6666011, page 25. You're dealing here with measures to promote the safe use of existing blood products, and you put forward, I think, 4 proposals for consideration. Really wanted to focus on the second proposal, which is the use of single donor or small pool cryoprecipitate for haemophilia therapy should be reassessed. In particular, the extent to which requirements of good manufacturing practice limit the production of small pool freeze-dried cryoprecipitate should be re-examined, and the costs of this product estimated in relation to intermediate factor 8 concentrate. Now, the issue of production of freeze-dried cryoprecipitate would be an issue for, is this right, essentially the PFC and or SNBTS working together?
My understanding of this was that certainly in Scotland, it could only have been done in the fractionation centre. And one of the problems, which is detailed in a long letter from Mr. John Watt to Professor Cash around this time, was that if it was to be manufactured in the fractionation centre, it would have to comply with all the GMP requirements of essentially of a licensed product. And the view stated in that letter by Mr. Watt was that would require a large and expensive investment in the fractionation centre. There were, and even interpreting that letter with a few grains of salt, there clearly were very significant technical and regulatory barriers to doing this in the UK. It was done in at least 2 places in Europe, one in Groningen in the north of Holland, and one in Belgium, and I can't remember the city. It was a Dr. Vermeulen who championed small pool freeze-dried cryo, and certainly made quite impressive claims about the extent to which the haemophilia population there could be managed using this product. I never had the experience of visiting I did visit the Dutch centre a number of cases, but I was never privileged to meet any of the patients or the people actually treating the haemophilia. And although various people from the SNBTS did visit Belgium, my recollection is that they came back not very impressed with the potential of this program. And as you know, the decision was taken not to continue with the development of freeze-dried cryo on a scale appropriate to meet substantial part of donors' requirement, or patients' requirements.
And that was the work that had been undertaken at is it the Law Hospital?
The Law Hospital had, which was the location of the West of Scotland Transfusion Centre, had a a freeze-drying plant, which had originally been commissioned, I think, shortly after the Second World War. I mean, it was an old machine, which they used to produce freeze-dried plasma, which was a product long since obsolete for some good reasons. And they were able to produce relatively small quantities of freeze-dried cryoprecipitate using that machine. They did a very small clinical evaluation of it, not really a trial, which they published, stating that they had no problem with adverse reactions and so on. But unfortunately, the number of recipients was small, and there was actually no data in the publication. And shortly after that, the inspectorate declared that the freeze-drying plant in Glasgow could no longer be used. It did not meet minimal GMP requirements. And it sort of died on its feet, really.
Leaving aside the possibility of re-establishing some form of production of freeze-dried cryoprecipitate, was the first sentence of this paragraph or of this proposal also aimed at potentially a degree of reversion to cryoprecipitate, at least pending perhaps the development of a test?
I was expressing an opinion which the haemophilia specialists would say was not an informed opinion, and they would be right. But I suppose I was, to some extent, still harking back to my teaching from Dr. Howard Davis, that, you know, I believed on sort of simple epidemiological grounds that small pool material made from the indigenous population would be safer. I have to add to that with the knowledge available now of the prevalence of hepatitis C in the community, and I have included a sort of simple statement about this in my evidence. It's less clear that there would, for a severe haemophiliac requiring fairly substantial and regular quantities of cryoprecipitate, they would, in the absence of hepatitis C testing, still have been exposed to the virus and probably become infected within a relatively short period of a year or two. I can't remember the paragraph reference, but I have given that information in my statement.
You have, of course. That wouldn't be the same in relation to the risk of transmission of HIV.
It wouldn't, no.
And did this?
The prevalence of HIV was very, very much lower in the donor population.
Do you know whether this paper that you produced, this report, was sent to your Haemophilia Centre Director colleagues?
I'm sure it was. I have no evidence now of the circulation, but I felt, you know, I had been privileged to attend that particular meeting, and there was nobody, apart from Mr. Watt, there was nobody else from the UK there. So I had a responsibility to sort of spread the information as widely as I felt I reasonably could. And I think it did find its way by various channels to a lot of people.
Now, I want to pick up next the Aids leaflets. We won't, I think, complete this topic before the end of the day, but I want to make a start. But before we look at what you produced in the course of 1983, I just want to ask you to look at a letter Dr. Cash wrote in 1990 to the Scottish Chief Medical Officer, Dr. Coleman. It's NHBT 40/190_063. It's headed Blood Donor Self-Exclusion Leaflets, and Dr. Cash says there's been a tradition in Scotland whereby the content of blood donor self-exclusion leaflets has been the responsibility of the SNBTS directors. Although we've always advised SHHD medical colleagues of our deliberations, there has been no requirement for SHHD clearance. The issue has hitherto been regarded as a professional matter. The significant advantage of this approach is the speed at which the SNBTS can introduce change, most often triggered by the WHO and/or FDA/NIH, and this is further accelerated because we print our own leaflets. The position in England and Wales is somewhat different. BTS professionals make proposals to DOH, and in due course DOH vets and thereafter prints the leaflet. The consequences of these different arrangements is that the leaflets have not been identical, but more importantly, Scotland consistently introduces change many months ahead of England and Wales. Now, we'll look at some of the details of the leaflets themselves in 1983, but broadly speaking, it is what Dr. Cash sets out there in relation to the position in Scotland, consistent with your recollection?
Well, to some extent, the first leaflet was definitely issued in a sort of UDI by the Southeast BTS. I do remember very clearly that we worked on a few drafts, and then eventually, I decided we needed to get on with, we needed to do something, and we'd spent quite a lot of time trying to agree wording with the homosexual group I described before, and I remember I telephoned Dr. Bell, who was my medical liaison in the department, in the SHHD, and I basically told him I was going to do it because I didn't want to ask. I felt it was a sort of seek forgiveness, not permission situation, really. And I just really wanted to get on with it. Now, at the time, I understood that he was okay with that. Subsequently, I've seen some correspondence that suggests that he was actually had second thoughts, which he did not communicate to me. But then what happened after that, I was extremely bemused about when I was trying to prepare evidence and do my oral exam, be examined in the Penrose inquiry, because I really could not remember what happened. But the next thing that emerged was a leaflet which is it's in your archive. It's PRSE 0004076, which is the one that has will you be asked about, will donors be questioned on sexual matters? It's definitely not. Now that's an NBTS leaflet, and I finally sort of was able to discover a little bit from Dr. Walford's evidence that this leaflet had been prepared, I think by Dr. Gunston originally, based on what I'd done, which was entirely based on the American guidance available at the time. And then it found its way to the department, and obviously Dr. Walford had been involved in some quite brisk discussions about it. The result was there was considerable, significant changes were made to the leaflet by, I don't know, it was called then Central Information Department or something, but they were rather sort of, they weakened the sense of the document. And I was asked, bearing in my S9 request, whether I'd been, whether I had written those or I was aware of them or involved. And I said I couldn't remember, but I couldn't imagine that I would have agreed with some details of the wording of this leaflet, because I felt they were inappropriately reassuring. They weren't tough enough, really. And I discovered again reading papers for this inquiry that view was actually shared not only by people in the department, but by some of the transfusion in the DHSS and by some transfusion colleagues. And there's a letter from, there was some correspondence between myself and Dr. Wagstaff, which seems to relate to the drafting of a follow-up leaflet, which was again produced in England, I think, but was labelled up for all the transfusion services, which had gone some way to modify this, slightly weak leaflet that had been produced. After that, to be honest, I really can't remember what the sequence of events was. There were numerous redrafts, and whether they were all done as national leaflets or whether some of them were done as local initiatives, I can't remember now.
And I think the documents don't provide a very clear answer in that regard. Just so that we can get clear, we can take that letter down. Thank you, Sally. We'll look at the wording of the leaflets tomorrow morning, Dr. McClelland, or material differences between them. But just to get the sequence of events, just for 1983 at the moment, right? My understanding, based on your evidence and the documents the inquiry has, is that you prepared, with colleagues in the South Eastern Service, your first draft in around May 1983. That was then issued with a slightly revised text. Again, there was various issues relating to drafting by the South East Regional Transfusion Service in June of 1983. And then it appears that in September of 1983, your Scottish leaflet was replaced by the leaflet that was produced in England and Wales. Is that consistent with your recollection?
That's my understanding.
Okay.
Yes, I have one of the very early TypeScript drafts here, which is indeed, it's got Dr. Smith's name on because we worked on it together. But and she was the donor consultant, so I wanted her to be the signatory. And I see it was actually item 15 of the transfusion directors. I think the Scottish Transfusion Directors meeting on the 24th of May. So it was communicated to the other Scottish directors as we were working on it.
And I'm just going to refer briefly to one of your written statements to the Penrose inquiry. There's no need to put it up on screen, but the reference for the transcript is PRSE 0002627. You had been asked to explain what lay behind your decision to draft a leaflet, and you said this. I cannot claim to recall... sorry, I will put it up on screen. It's fairer to you, Dr. McClelland, and probably more useful for those following. PRSE 0002627, and it's the second page. So it's just the last paragraph on this page. You say, I cannot claim to recall my thought process in early 1983 when we began to work on the leaflet. I was aware of the evidence that had started to emerge in July 1982 that AIDS was transmissible by blood and was therefore more likely to be due to a transmissible infectious agent than to any of the other causes then being considered. I think it would have seemed fairly obvious then that it was important to take whatever action we could identify to reduce risk to transfusion recipients. I do recall another factor that increased our awareness of the need to take some form of preventive action against the risk of a blood recipient contacting AIDS. During 1983, one or two local newspapers took up the suggestion that Edinburgh could become the AIDS capital of the North, arguing A, that AIDS mainly affected gay men, and B, that the Edinburgh International Festival would selectively attract individuals at risk of AIDS. So that, as I understand it, is what essentially, doing the best you can looking back, is what you think led you to take the initiative in drafting a leaflet for the South East Service.
Yes, I think the other factor was that I had thought about what to do before that, but we didn't have any local clinical, as it were, experience, real hands-on experience to to be sure, quite how we should formulate the leaflet, and particularly the exclusion criteria. So when I saw whenever I saw the first American CDC Public Health Service recommendations on donor exclusion, that gave me the information that we needed. I felt confident that if we essentially reproduced that wording, it would at least be based on the experience of people dealing with quite a much further advanced epidemic. And I was much more comfortable just to repeat that verbatim, essentially. But that was a factor that encouraged us to get on with it.
So I note the time that there's quite a few documents we're going to need to look at in relation to the leaflets, so I think probably best to do that fresh in the morning.
Very well. Well, let's take a break now then, and come back tomorrow morning at 10 o'clock. 10 o'clock.